Ashay sir. After these two wonderful talks by Dr. Mansi and Akhil, where we saw a lot of clinical work and what we do regularly in clinical practice, I'll be discussing a bit of topic where most of the data or most of the studies are in still phase 1 or early phases of their progress. So I'll be discussing the resistance mechanisms to osimertinib. As has been already discussed, osimertinib is irreversible inhibitor of the EGFR sensitizing and T790M resistant mutations. Osimertinib binds irreversibly to the cysteine 797 located on the ATP binding site of TKD of the EGFR. And Aura and Flora have set the ground for approval of osimertinib in the second and first line study settings respectively. But with this, what has happened is we are using more and more of osimertinib. Akhil rightly pointed out that yes, in India we use it less commonly in first line setting, or even in second line setting. But yes, there are a good number of patients out there who are on osimertinib even in first line now. And what next comes the question: what do we have in our store for all these patients who may progress on osimertinib one day, sooner or later? So just this one picture shows that as of now, whatever data we have from the patients who had progression in Flora as well as Aura studies and in few other studies, almost in 60 to 70% of the patients, in whether we have used osimertinib in first line or in second line, we have definite driver mutations or oncogenic fusions or amplifications, genetic alterations, which can be detected if we do a liquid biopsy or a biopsy from the progressing site. And these are the mutations, alterations that I'll be just discussing very briefly in this presentation. But yeah, as this slide shows, that almost 30 to 40% of the patients, we still do not know what is the exact driver for this resistance to osimertinib. This is a very basic diagram showing the cell surface receptors of EGFR, AL, KRAS, RET, MET, and HER2. And the key to understand the resistance mechanism lies in this simple image, that the resistance is driven by EGFR TKD domain mutations or by EGFR-dependent mutations and alterations that happen which cause resistance to osimertinib, or it can be driven by other alterations which may be happening in either HER2, MET, RET, RAS, RAF, or PIK3 sites. Coming to the first group, the EGFR-dependent mechanisms of resistance. The most common is the mutation happening at the C797 site, the osimertinib binding site. This accounts for around 7% of the patients who have received osimertinib in first line and around 20% of the patients in second line. The strategies to overcome this particular resistance mechanism include giving either osimertinib plus erlotinib or geftinib a first generation TKI, because the binding of these or the effect of these drugs is not dependent on C797. So there are case reports showing a PFS of 3 to 5 months with this particular combination of third generation plus first generation TKI. Adding bevacizumab has added another few months, increasing the PFS to 8 months. There is a retrospective analysis of use of brigatinib plus cetuximab in this setting. And here again, we have seen an overall response rate of 60% with a good PFS of 14 months. Patritumumab deruxtecan is another drug in the pipeline. It's in development. It is a HER3 targeted antibody drug conjugate with an overall response rate seen in about 39% of the patients and a PFS of 8.2 months. There are studies being done to try to prevent such kind of a situation from happening. And one of the studies is a phase 1/2 study undergoing, which is combining osimertinib and geftinib from day 1. And the tolerance has been fair till now, what has been reported recently. And fourth generation TKIs are also in development, but most of these still do not have any names. They are just in letters and numbers. And most of them are 5 of them are in phase 1 studies. Coming to the less common EGFR dependent alterations, G796, L792 mutations, the exact mechanism or the exact evidence of functional effect is not yet clear, but most probable mechanism is thought to be that they interfere with the interaction of osimertinib with its binding site, which is the 797 residue. The third group amongst this EGFR dependent mechanisms is EGFR amplification. Almost 30% of patients in this subgroup will be having EGFR amplifications, and there is an ongoing study which is combining osimertinib with necitumumab, which is an IgG1 monoclonal antibody with an EGFR antagonistic action, and the results of this are also awaited. The next major, so these were all the mechanisms which were EGFR dependent. Coming to the next group of patients who have osimertinib progression, so that is histologic or phenotypic transformation. And so the two types are either small cell transformation, which we have known about, and some of the patients may also have squamous cell transformation. Small cell transformation is seen in around 6 to 15% in second line settings, while it's seen in only around 4% of the patients who receive osimertinib in the first line. Most of these patients are known to continue to have EGFR mutation expression on their even after transformation, but the expression levels drop, and this explains why osimertinib or EGFR TKIs are not much useful once there is transformation to small cell. The common mutations associated with this particular transformation are mutations in the TP53, RB1, and PIK3CA genes. There are retrospective analysis showing that the most useful protocol or most useful treatment is, as we all know, etoposide and platinum combination, with response rates near about 54% and a PFS of 3.4 months, with a median OS of around 10.9 months after transformation. To be noted is that none of these patients had response to immunotherapy to combination of nivolumab or nivo-EP. And an ongoing study is looking at the combination of osimertinib with etoposide and platinum. The next subgroup amongst this will be the squamous cell transformation, seen in around 6 to 7% of the patient who are receiving osimertinib in first line. And here there is no particular clear molecular pattern which has been evolved till now or detected till now. And currently the treatment will be based on histology. The third subgroup after EGFR dependent and histologic transformation, the third subgroup is MET amplification. MET amplification, it is the second most common alteration after C797. And it is seen in around 9 to 24% of the patients in second line, 7 to 15% of the patients in first line. There are multiple studies which are ongoing. The TATON study has combined savolitinib with osimertinib and has shown an overall response rate of 30%, PFS of 5.4 months. Lazertinib, which is another EGFR TKI, third generation TKI, just like osimertinib, it has been combined with amivantamab and has shown an overall response rate of 50%. Tepotinib, another MET inhibitor, in combination or just by itself, is being studied in INSIGHT-2. And we have case reports of osimertinib with crizotinib showing a PFS of 2 to 7 months. HER2 alterations form the next subgroup of such patients with osimertinib resistance, seen in around 2 to 3% of the patients. Again, the studies, the drugs or the trials here are involving patritumumab deruxtecan, the HER3 targeted antibody drug conjugate, osimertinib plus lapatinib or neratinib, osimertinib plus patritumumab, and trastuzumab deruxtecan. RET alterations make the fifth subgroup. RET alterations can be either substitutions or fusion proteins, and they are seen in around 2% of patients with EGFR osimertinib resistance. There are case reports of combining osimertinib with selpercatinib. BRAF alterations, BRAF V600E is seen in around 3% of such patients, and 1 to 2% patients will have BRAF fusions. Combinations of osimertinib with BRAF and MEK inhibitors have been shown to give some success in the terms of response rates or survivals. KRAS mutations, G12C mutation inhibitors, sotorasib, adagrasib are already there, and combinations of osimertinib with these drugs are being tried in similar patients. And these particular mutations are responsible for around 5 to 6% of patients who progress on osimertinib. PIK3 alterations is another subgroup, and it is seen in around 6% of patients who receive osimertinib in the first line. And around 15% of patients who have been on EGFR TKIs, whether first line or second generation TKIs, show PIK3 CA mutations or PIK3 plus P10 and AKT mutations. And there have been attempts to combine everolimus, the mTOR inhibitor, with EGFR TKIs, showing like out of 6 patients who were studied in this, who were reported in this case series, 5 showed a stable disease or partial response for 4 to 5 months, while 1 had a progressive disease. The ninth subgroup of, or ninth cause of mechanism, or ninth cause of resistance, is the cell cycle gene alterations. CDK4 and 6, as we know, are major oncogenic drivers, and the genes associated with these CDKs are the CCND, CCNE, and CDKN. The mutations in these particular genes have been documented in 12% of patients who had progression in the Aura trial, and around 11% of the patients in the Flora study. And these genetic alterations, as we know, are associated with poor outcomes. Osimertinib in combination with CDK4/6 inhibitors, palbociclib and abemaciclib, is being studied. Well, but this study is not actually in patients who have received osimertinib in the first line, but let us see what it comes out with. AXL overexpression, something new which I learned while reviewing the data. AXL is an receptor tyrosine kinase, which is again related to cell growth and proliferation, motility, and invasion and epithelial-mesenchymal transition. AXL overexpression has been associated or has been reported as an acquired mechanism of resistance to first and second generation TKIs, as well as to second line osimertinib. Its presence has been associated with decreased response to first-line osimertinib if it is present in the baseline itself. And a drug named enaputamab vedotin, which is an antibody-drug conjugate targeting AXL, which is specific to AXL, is being studied in a phase 1-2 trial presently in different tumors. It's a basket trial. Insulin-like growth factor 1 receptor activation. This activation has been reported in vitro studies, not actually in human studies or like that. And again, an in vitro study showed that a combination of lincitinib, which is an IGF-1 receptor antagonist, combining it with osimertinib, has sensitized the cells to osimertinib. So this may be something which we may see in future. Epithelial-mesenchymal transition, again, something which is more documented in cell lines and in vitro studies, showing downregulation of E-cadherin while upregulation of N-cadherin and Vimentin, depending on the TGF-beta, SMAD, and MAP kinase pathways and EGF-1 receptor induction. This has been known to cause increase the invasive capacity, and as well as known to cause resistance to different treatments. It has been documented in vitro studies that EMT is an additional mechanism of resistance to osimertinib. And probably these last 2-3 mechanisms which I discussed are responsible for those 30 or at least a few of those in whom we do not understand or we do not know the exact cause of resistance to osimertinib. With this, I'll just say that resistance to osimertinib, or I'll summarize saying that resistance to osimertinib can happen due to kinase domain mutations, or it can happen with activation of bypassing signaling or phenotypic transformation. So 3 major subgroups or 3 major groups of resistance mechanisms. And all these novel approaches are at various stages of clinical investigations. These include antibody drug conjugates, combining different various TKIs, 4th generation TKIs, and immune directed approaches. What is of most importance is that, yes, every time there is a progression, we should ideally try to get a rebiopsy. And if that's not feasible, go for a liquid biopsy if that's affording, if the patient is affording. And one of the challenges over here will remain for some more time with us. It will be multiple alterations are found, and it is difficult to elucidate which is the exact driving mechanism of this resistance. And only when we know that we'll be able to understand which treatment we should choose for our patient. This is a summary showing, this is a table showing different incidences of different mutations and alterations causing resistance to osimertinib, and their treatment strategies are over here. With this, I thank you for your attention. Thank you.